So I farm so hard, the employees wanna find me, and then wanna hire me. What's 100K to a guy like me? Could you please remind me? Farm so hard, this ain't easy. Working late nights, you best believe me. My grades can only go A's. Never wanna see another B unless I'm Jay-Z. Farm so hard.
What's good, thanks for aka PharmD to ED, and I'm coming with my co-host, the person who helped us start all of this together, the man, the myth himself, Dr. Oscar Santalo.
What's up, guys? Good talk. It's like fell off the face of the earth, and now we're back at it again with our shenanigans. So thanks for bringing me back, Jimmy. I appreciate it.
It's been a pleasure, man. And I just think as we went back, this has been since 2019 when we started this. And I think life has been great for us in many areas, but I think we both, you've ascended to a lot more of the formal leadership. I've gotten some other leadership, but I think it's been insane to go from residency to where we are today. So super excited to get you back on. But let's get straight into this. Oscar, tell the audience what we're going to be talking about today.
Some ED shenanigans. So, just so you guys know this, yeah, like Jimmy mentioned, I'm Oscar Santalo. I'm the director of pharmacy at Advent Health Winter Garden, part of our Central Florida division here within the company. So, a little background on my side. So I have a fun-size 80-bed hospital. It's soon to be 200 beds. We oversee our offsite ED in one of our sites at Millennium. We oversaw another offsite ED. Yeah, so it's been pretty fun to see the growth and all the things that are happening in the area. I'm blessed to have a chief medical officer that is an EM physician. And he approached me with a problem. He's like, Oscar, I want a 24/7 bed service. Can you help me? And my response to him was, it's not that simple. At the time, we didn't have a physical pharmacy because we had just opened back in 2022, and we've been growing and blowing up ever since. And it's very competitive in our market with all of EDs, so we're trying to figure out how we can differentiate from all the other emergency departments. So, sure, some folks in the audience probably heard, none heard, but there are things called pharmacy kiosks or pharmacy lockers, where you utilize them for meds to beds. It's pre-filled bottled prescriptions. You throw them in the kiosk and you try to see, patient's going to pick it up or the nurse will grab it for them, those kind of things, etc. One problem we identified was that in our EDs, we had numerous ED revisits due to patients not picking up their prescriptions. In our area, actually in Winter Garden, there are no 24-hour pharmacies. We have a lot of kiddos in our area, so a lot of young families. So, a lot of concerned parents at 9, 10 o'clock at night when they bring their kids in and they can't fill their prescriptions the next day. So we're looking into options and how we could provide a 24/7 bed service, and that's how we landed on using a kiosk.
Perfect, man. I think people just need to understand too, just like, again, it's almost like I know like 1 in 5 of my patients are going to have some type of issue medication related. So for me, I think of this ways, and I had a similar issue where my team was saying, hey, we need to figure out how to get these medications and figure out how to get these patients out of the hospital, because I would have patients sit in my ED overnight waiting for our discharge pharmacy to open. And that was a major deal as well. So we're trying to figure out, okay, if from an ED throughput perspective, that was something that was really significant to me, and figuring out how can I go about this in a way that can provide an option for them. I told them, I said, hey, well, give me some more pharmacists and we can help fill some of these scripts overnight. That wasn't necessarily an option, but a thing that came up was going to be figuring out a different way to do some type of kiosk. Because again, even with us having clinical pharmacists overnight, sometimes we need something to help us be able to go from there. So I think a lot of people are facing similar problems when it comes to this. But I think you guys really looked at this, and I was super excited once you sit over the paper and the team looked at it, and I was like, this is something that most EDs could be able to handle. And it was really cool for us to kind of bring together our background to one place.
Yeah, and it was the first time ever you considered beds in the ED. Like, I know a lot of places tried, but most retail pharmacies are open during business hours. When are the ED's busiest? Evening and overnight. So when they finally approved our retail pharmacy, and by finally, like just by like they've been very pro C-suite campus, so very grateful to be here. The concern was for my CMO was like, well, what about the ED? It's cool we got the physical pharmacy, but it's not going to help the ED hours, and that's kind of why pushing the kiosk more towards it being used in the ED. And the other reason why we liked it because it's a pretty niche formulary. The most common prescriptions that we'll see are Zofran, ibuprofen 800. You have your Keflex, your Doxy, those kind of things. So we felt like it was a pretty niche formula that we can have majority of the meds. So we ran and did our analysis. 80% of the medications that were globally sent in our emergency department actually fit our formulary. So we knew that we had an opportunity to like have a pretty decent capture rate for that. The only major limitation that the kiosks do have, and it's up to your state from a regulatory perspective, is going to be if you have controlled substances. Can you have controlled substances? No controlled substances. A little gray because ideally, when you look at the statutes for kiosks, they're actually made to be patient facing. In other words, like it's outside of a medical office building. It's in a clinic where the patient can go retrieve it. So that's how most of the statutes read. It doesn't really lean into if you want to use it as a clinician and you're literally the one putting the prescription in the patient's hand. So I know that there's pharmacy lockers out there, and this is when we're doing our analysis, like, hey, like which kiosks are we going to go with? Some companies use a pharmacy locker, which is great. And employees may know how to use a locker, but do patients. So you're going to have a discharged patient, geriatric patient, get rolled down when they get discharged to go to that locker and know what buttons and things like that to push, and them just kind of walking past it. So we wanted to make it easy. That's Advent Health. That's one of our service standards. We literally just want to put the prescription in the patient's hands so they can go out the door and they can focus on healing. So that was the rationale of us using it as a non-patient facing device. And it's very interesting how we had to come up with all the different workflows and things like that.
Absolutely. That was the thing that was unique about this, because I think a lot of people want to figure out the patient side of it, but I think allowing the pharmacist or the nursing staff or the physician staff to be able to utilize that to be able to get patients out is going to be a big thing. But I think now we can understand that the background of what got you there, because a lot of people will probably share that background. And I think that was the major deciding point for us. It's like, hey, we're just going to extend some of the hours that we have from our discharge pharmacy. We're still going to have this issue overnight for a period of time, but we're going to potentially have an overnight pharmacist. Again, we're 900 bed. We have, close over 120,000 visits a year. So we want to figure out what's going to be the long-term solution. And our leadership decided to go with a much more, this having a 24-hour discharge pharmacy that they're going to build. But I think in the meantime, between now and the years when our new building is built, this is something that really came front and center for me, especially with us hiring overnight pharmacists now. So I think this is how when I read it, I was like, this would be a good tool for the pharmacist, a good tool for the team to go from there. But let's kind of change gears here. We kind of talked a lot about the background and kind of understanding, why you guys went the way that you guys did. And then when you guys set this up, it's like the methods of all of this kind of, then you get to a point where you go from ideas of just doing that to actually studying this. Can you walk us through kind of like the design of all of this when you look at it from like a study perspective?
So it went back to what is the purpose of the kiosk, or what problem are we trying to solve? And for us, the problem we're trying to solve is prevention and prescription abandonment, right? And looking at our ED length of stay. The biggest pushback for the project wasn't, can you get the scripts, or even trying to break even. Like, they weren't worried about that. They were worried about delaying discharges. So that's why we chose those measures. Was prescription abandonment, because the utmost important, because we really felt like that was a definite risk factor for ED revisits, as well as, how much longer it's going to take for these patients to fill, the meds for that. So that's kind of where we landed on the design, and just a little background on just what the workflow is. Because like that was one thing about writing this paper was so hard, was because there's nothing really I could reference it to. So I can only really feel for the reader, like, wait, how does this workflow work? So in summary, the medications come prepackaged. We go ahead and we for Keflex quantity of 14, already prepackaged, labels cool, goes in the machine. Physician sitting on Jimmy's unit wants to discharge a patient, right? Sends the prescription over, and then it kind of goes into the pharmacist queue to verify that prescription. The nurse will go and release the medication, right? And then shortly after, they will check the patient out. And by they, it could be your patient finance teams, it could be your technicians. There's a variety of workflows that you can do. So that's kind of how that looks. And that's what they're concerned about, those steps. But we went back and looked at the data. So we looked at patients that used the kiosk and didn't use the kiosk. One major limitation, well, there's a lot of limitations, right? But one limitation was that this was a self-pay model, right? And part two, which I hope to come back and talk about a little more again, that we actually figured out how to do real-time adjudication. But for this scenario, it was just self-pay, so all the meds were $10. They kind of make it just simple, easy. It was cash we didn't have to worry about, because our other concern was like, hey, if we use adjudication, that would take more time trying to fight with insurance companies, and we didn't want to hold up a bed. We want to keep the patient moving. So we looked at our capture rates at that time. So it was roughly 8 to 15% when we went live with the kiosk as a self-pay model. And then we looked at kiosk patients and patients that didn't use the kiosk. And then we partnered with our community pharmacies and performed medication histories. And we contacted patients like, hey, we saw the script was sent. Did the patient pick it up? One of the things that we had to remove was if the doctor prescribed an OTC, we just assumed they got it because there was no way we could confirm that. So that was one of the limitations of the study. But we looked at our two different kiosks, one in our offsite ED and one at our main campus. And the reason why we looked at the two different kiosks versus one, because the patient populations were totally different, which is, I got two different extremes. My main campus, mainly commercial. The other side, mainly underserved, self-pay, etc. So we got two different extremes there. So what we saw for prescription abandonment, after following up with our local community pharmacies, the prescription abandonment at our offsite ED was roughly 50%. At the main campus, I apologize, 40%. At our main campus, it was 20%, and that kind of brought us to how we got to that 30% number. So roughly a third. And we were able to confirm that, double check the data and things like that. So we knew the patients were getting the scripts, and it was kind of interesting to follow up on those patients because we did some case studies and things like that, why I brought back, and we can kind of see like for UTI, they didn't pick up Keflex, they're back again. When we looked at the overall turnaround time, we actually saw no difference. Can't remember off the top of my head there. It was fairly close. I think it was like an extra couple minutes, and we saw those no statistical significance there, which is pretty neat. And the rationale was like, well, you're doing this whole filling and cause extra steps. So in our workflows, a lot of times the physicians send the prescriptions before they actually discharge the patients. So they'll start the discharge order process. They sent the prescription, and they might not discharge a patient because they're waiting for a lab or a test or something else. So it actually bought us time to do those things. So it was kind of neat that when the doctor initiated the prescription process or the discharge order process, the nurse was already prepping for discharge, would grab the med and get the discharge summary paperwork over to the patient. So that's kind of what we noticed. And then we were able to look at our turnaround times from a team perspective for the pharmacist. It ranged from 2 to 4 minutes for their verification turnaround times. For the nurses, it took them 6 minutes once he actually logged in, logged out. One of the major barriers to the project was just the communication, and that's something that we're still trying to work on, that enhancement. So it's like the pharmacist communicating to the nurse when it's time for the prescription to be released, and the nurse communicating to the pharmacist for the final photo verification, or when they're walking out the patient to consumer access for checkout. So it's a very multidisciplinary project, and we've had some significant updates since part one. It was that we couldn't really get the updates until we powered through just go live. So that was just the hardest part about the project overall, just being the first ones to kind of utilize this concept. And it's kind of a thing where you had to like show the need before you get all the enhancements that come with it, or not even that. They just want to make sure that you're requesting the right enhancement. You don't want to request a bunch of things and then say, nah, I don't want to use that.
Absolutely. You being admin, you understand the thought process of, okay, well, let me give you this. Let's prove a proof of concept, and then be able to build on that. And you guys was able to do that. Just for the audience to kind of think about this and hear it again. You mentioned that the prescription abandonment was going to be 30% in your other group. Again, what was for people to understand, what was the abandonment rate for the kiosk? Because I think that's going to be a big seller.
Like, you literally handed the prescription in the patient's hand.
Yep.
Like,
so 0% prescription abandonment.
That was the why though, right? Like, you literally put it in their hand, so there's no reason for you to come back, right? And that helped out the provider significantly, because now like for some underserved sites, patients are using these OSEDs like a primary care, right? So if you're reducing those ED revisits possibly, you're actually freeing up your doc to actually care for more patients, right? Actually for more complex patients. You're not pulling them into primary care needs, and they don't know that because they're going to fully assess the patient regardless, right? So that was a huge satisfaction. It was really eye-opening to the doctors. They're actually frustrated because you got to look at it from their lens. They took their time to come up with their assessment. They had a treatment plan. I'm going to send you on this script. This is who you're going to follow up with. And the patient only had one job. They didn't go get their script. So that was an aha moment for a lot of them when they saw that, wow, it was a third. And at this site over here, at my higher risk patients, it was 40%. So that's what actually helped increase my capture rates afterwards when they kind of saw that. And I think in this analysis too, we did look at ED revisits and saw those no significant difference in an outcome. It was always 3 to 5% as well. And I don't think, and even in the next study that we have coming out, I don't think in any readmission data, revisit data, you're not going to have medications or meds to beds be the sole reason why it prevents the readmission or there's a ton of factors, right? Yeah. There's numerous studies that prove that, but if it's one of the high risk factors, it can help a little bit, right? So anything that we could do to threaten, so 2, 3, 4, 5% may not sound like a lot, but if you're an organization that has 300,000 ED, that's a big number, right? And it's the right thing to do for the patient. And from a consumer perspective, that's something that, as from pharmacy or just anyone in general, we got to move towards that. Now it's got to be more consumer, patient focused care, right? Like, they want their refills sent home to them. They want to buy their prescriptions off of Amazon. So I think from a hospital method beds perspective, we got to be forward thinking in that regard also.
Yeah, and the way I think about it too, when I first deep dive this, and I said, well, some people would say, oh, it was 10 minutes more. I was like, well, you got 10 minutes of process to prevent them coming back within 72 hours. So to me, that was a really big thing to be able to say, hey, I know I can reduce this amount here. Yeah, think if I had 1,000 patients, again, what would that number look like? Again, you mentioned some bigger organizations and then you're looking across the enterprise. And again, you understand, and most hospitals most people are listed as are part of an enterprise now. We're getting to the point where it's going to be like 5 mega systems, and some of these things will be happening across the board, and we'll be able to have data across the board. So I think for me, when I first saw this, I said, well, you buy me 10 minutes, but you save me 72 hours. So that's the thing. It's like, I would rather take the extra 10 minutes to prevent that patient from coming back in 3 days.
The patient's waiting for an hour at the pharmacy.
Yep.
Right? They're waiting an hour at the pharmacy, and what we saw in our analysis, it was over 40% of the prescriptions were sent in their hand.
Yep.
So, and that's delaying care and everything, stuff like that. So that was one thing we were like, made sure we saw, like, how when the scripts were flowing through and things like that. But yeah, majority of the night because of the pharmacy off hours. And it does help the retail pharmacy because, and by the way, like these meds, and I'm back up a step further, this wasn't like a money-making project, right? We knew that we were lucky if we broke even because, dude, this is Keflex, this is doxycycline, this is ibuprofen. You're not making money off these meds. So we knew the reimbursement or even the self-pay model was going to be low for that. One thing we did identify in the study, which is actually very interesting to me, was the self-pay versus the insurance. Because we eventually went live with insurance, and that's a whole other topic for another day on how that's automated. But the reason why we went from self-pay to insurance was because it wasn't pharmacy or the patient. It was the clinical teams, because they felt like they weren't equipped to have those conversations. Like, hey, by the way, script's gonna be $10. They're like, well, why can't I use my insurance? And they're like they really struggled. And we wanted to make sure we were protecting our clinicians, nurses, and providers, that they weren't in those money conversations, right? But there were times where the patient would ask, like, hey, well, how much is it? Or can you run it through my insurance? And that wasn't necessarily fair to them for that, because we don't want patients to think that we're dictating their care and trying to make money off of them, right? We're making the best clinical decision for the patient, irregardless of how much things cost or if we're going to make money off of you. So that's why we want to pull them from that conversation. Thankfully, we didn't have that. So that was an interesting find, and it wasn't the patient, it wasn't pharmacy. Pharmacy, we loved it because we had to deal with insurance, right? So we didn't. It was clear. I didn't have to worry about any of the adjudication fees and things like that. So it was much more. But I think just to ease the needs of our teams, right, to get them out of those awkward conversations, we went to adjudication and saw a significant increase because now they're even more engaged, right? And they felt bad too that the patients were paying $10 where their meds would normally be covered out of their pharmacy. So there's a lot of different concepts on that. Some people are like, well, you're paying for the convenience of it. So if you go self-pay model versus you try to utilize insurance, that's up to your campus, your organization. We were just asked by our clinical teams, like, hey, can we at least try to run things through their insurance? They felt like it was the right thing to do, and that's fine. And that got our volumes up, and that helped us prevent further revisits, prescription abandonment, etc.
Yeah, and the way I think of this is like a lot of some people could think about this from an operational perspective and something that's going to be great. One thing that I remember looking at when I looked into discussions was that we noticed an increase in pharmacist interventions due to this data. And again, for therapy optimizations with different, antimicrobial stewardship components, do you envision like the scope of this being able to help ED pharmacists? Because I think sometimes when you add a machine, people get worried about taking the clinical pharmacist out of it. But do you envision this, helping out with some of these outpatient stewardship and transitions of care?
This was a cheat code. This was great. So two separate stories. So most community chain pharmacies don't have access to your EHR. Our team has access to our own EHR. So routinely, they're writing antibiotics, and my pharmacists were actually looking through the charts like, hey, we should be able to change this antibiotic here. We think it'll be a better treatment course, or hey, I think you need to update the duration, etc. So we intervened a lot. Kind of hard to track because we verify things in a different system, but when I see like the delays or the turnaround times were a little higher, we were able to identify that, oh, that's because the pharmacist was trying to intervene on that, which was great. And that's not a knock on the chain community pharmacy guys. It was just that they don't have access to the level of information that we had, right? So that was a great number of interventions. Also, too, is just the why was great for the pharmacist, because you might have some clinical pharmacists like, listen, I chose to do inpatient, not retail. It's the reason why I chose to do residency, right? And my biggest thing was like, well, as a pharmacy leader, right? So those that work on this project, pharmacists may not want to be doing this kind of work. So I kind of explained something like, all right, why don't we like retail work from a hospital pharmacist perspective? Could be because dealing with insurance. It could be because negative patient interactions, right? Handling money, right? And in this project, those are the three things we really didn't interact with, right? So I made sure, like, hey, you're optimizing therapy. You're doing your core pharmacist work. I'm not asking you to be a retail pharmacist. And once they kind of see the workflow, they kind of felt a little more comfortable. And the one pharmacist, there was an amoxicillin suspension that was ordered 10 o'clock at night that they verified. And when they got there, and by the way, we did have a protocol, and we could kind of outline the requirements of that protocol where the company would donate or eat the cost of the medication. So it was a self-pay family, 10 o'clock at night. They had a severe ear infection that they were worried about it going into other places. And they got escalated like, oh, hey, like there's something they can't afford it. Cool, like we'll write it off. Pharmacist approached me the next day. He's like, hey, what would have happened if that patient couldn't get the med? Or like we couldn't do that for them. I don't think they're getting the med. The CVS is not giving that medication, or unless there's payment or they run discount cards, but highly unlikely they're getting that medication. So that's the why for the project, is that there are patients. We're increasing medication access and experience. So it's been a very hard project. I'm not gonna lie to y'all, but it's been a very, very rewarding one as we navigate through this. And I feel like our roles, everyone's having a transition of care role now. I feel like it doesn't matter if you're ED, IM, ICU. So it's like you're already thinking about discharge and following up with patients. Like now you're thinking like, are we setting up for success after they leave now, right? So it's like our whole patient care that we're trying to provide here. And I feel like, having the kiosks, mezza beds, keeping that patient in your network gives you a great line of sight for that.
Yeah, and speaking of some of the challenges, when you look at this, one of the barriers you guys mentioned in here was kind of the lack of this EHR integration in a sense, and how the communication between pharmacy, nursing, different leaders. Again, what technology or workflow? I mean, you guys mentioned that you have some workflow improvement stuff now. Can you kind of talk about some of that issue?
So the kiosk that we used in the article was Adherent 360, their kiosk, right? And there's a ton of kiosk stuff out there that you can use. There's some that actually already have Epic integrated. There's some that don't. By the way, it doesn't matter if it doesn't. It still functions as a pharmacy. It's just how the billing and all the behind the scenes stuff work. The reason why we went with Adherent was because this was the first project and we knew that the reimbursement was going to be real low. Also, their level of customer service and things like that. We felt like it was going to be the best kiosk for us to use in the ED. There are different kiosks where it will label and dispense the medication to you. There's some where the labeling is externally, where it prints out after you get the med and you slap the label on it. So there's somewhere like you get the med and you have to type it up. So all the different kiosks have different workflows. You got to find the right one for you, right? So we elected one that, just from a cost perspective and just from what's the word I want to use? It was just very user friendly. Like I was able to customize the formula. Like we're able to dispense nebulizer devices. Do you know how many patients get albuterol nebs and they don't have a nebula? So like we got it at a reasonable price where it's significantly cheaper than what you get on Amazon and things like that. So little things like that we've been able to do outside the kiosk to make sure those patients can get those things. So that's how we landed on them. The lack of EHR integration, like integrates like it sends a prescription, but it may not pull all their information for you, or it may not flow financially. So really having to include all the different disciplines on each part, learning on who has to look at the adjudication, reimbursement, reconciliation, like those kind of things, which is already kind of a manual process, but it was different. Like instead of looking at your EHR for the information, you look in the Adherent 360 application. So it's been somewhat manual, but we found a way to include it in everyone's workflows. So those are just some of the many enhancements that we're working on. So like one of the newer enhancements, like I said, major barrier was communication. So now that they actually did a wonderful job and helped us increase our communication, they developed a nice tracking system where you can see all the steps, how you get notifications, how you can communicate to one another in the application. So that's one of the many things. One of the other great enhancements that they've done is that the adjudication, like how to go level adjudication. So what I didn't want was my pharmacist was to call the patient and ask for their prescription cards. That was definitely a no-go, especially in the ED. So like one of the newer enhancements that they put out there was that once we verify the prescription, it automatically gets submitted through SureScripts, comes back, pulls their insurance information. So it's already done for them. It's actually really great. So really doing my best to protect my inpatient team from doing traditional retail pharmacist work, because that may not be in their hearts of what they want to do. But if I make the workflow as seamless to what they're doing currently, and that's kind of what we tried to do with all the other disciplines. how do we incorporate in the workflow something that's already doing? Yes, it is another thing you have to do, but it's not different. It's not an outlier. Consumer access, you're still collecting money, right? The nurses, you're still initiating the discharge process, right? Pharmacy, you're verifying prescriptions. Doctor, you're sending prescription. So we're not doing something too different, right? It's just another thing we have to do. And but once you communicate the why to the project, like everyone was eventually able to rally behind it.
Yeah, and that's one thing I think people need to realize. Like, if you spend, because I have patients waiting in my ER for 10 hours. So if you tell me I can spend 10 minutes and I can free a bed up that would have been held for 10 hours, or more. I've had some patients that come in, particularly, I think the next step for me is figuring out how do you deal with things like Suboxone? How do you deal with things like methadone? How you deal with those? And I think that's going to be a little bit more state specific. I think it's a little bit more challenging to figure out that overall. So that's a kind of an institutional and a bigger thing. But for me, it's like my Eliquis. Some people have some take home kits for that, but this is respiratory season. I would love to have albuterol inhalers, nebulizers, all these different components that really help out.
Yes, all the flu meds and things like that. We have all that stuff in there, like prednisolone. So yeah, so like, and every kiosk is different how much they can actually contain in their formulary, right? So like our kiosk, they can hold up to 70 line items and at least up to 10 packages in each one. So it's 700 to 800 items that you can carry in that device. So it was actually pretty neat. Other kiosks can hold more or less, right? It's all depending on the packaging or what specific you're putting it on. Are you getting your items through a repackager? Are you doing it in-house, right? So that's why you do need some pretty creative retail pharmacy or ops managers, inpatient, to kind of figure out like, it's kind of like a picture, right? How do I optimize the real estate with the drugs that I have, what I need, how do I update the PARs and stuff like that. So we've been able to be pretty creative and stuff like that, but it's been a blessing starting it in the ED because the medications are already pretty niche. So we already know like Zofran, ibuprofen, Keflex, amoxicillin, albuterol, like the meds are pretty consistent.
One of the things that also I mentioned that I saw in the discussion was like the amount of FTEs you recommend for like a technician. I saw like 0.2 to 0.5, depending on your capture rate. What do you think is going to be like the most realistic, again, for maybe an ED of my size? I have like 80 beds and again, 120 again or do you kind of anticipate this having some diminishing returns and increasing workflow for pharmacists?
Great question. Just time study it. That's kind of what we did. So I was able to see how long it takes. So in best case or worst best case scenario, right? So I was able to see, or the vendors would help me with this data when I saw that once they actually log in, right? Once they can get into the prescription, how long does it take them to verify it, right? And by the way, these scripts are off of an order set. So it already smooths out a lot of the troubleshooting. We had scope to clean up the prescriptions, right? So it was a very easy pharmacist process, right? It's like you're enforcing criteria for use. You know what I'm saying? So it's already off an order set, and you had scope to clean things up when necessary, and you had access to the patient's chart, right? And if you're ED pharmacist, doc's right there, right? So our normal verification times was like a minute to two, right, on the initial DUR, or sorry, like 2 to 3 minutes on initial DUR, and 1 to 2 in the final verification. So you take your 3 to 5 minutes and you assume your capture rate. So we were assuming 30%. Unable to hit that target yet consistently. So that's what you got to figure out. Like, what is my target? All right, let's say we do 20%. If I capture 20% of my prescriptions, that's how long it takes my pharmacist to verify it. That's how many dollars or hours I should get. For my technician to refill it, or if I'm packaging it, how long does it take for them to do that? Right. And those are some of the things that we're able to get down granular, and it was based off of time studies. That's why we got the 0.2 to 0.5. It depends on the volume and how you fluctuate that. Essentially, some of the work is going to be absorbed, right, between nursing or some of the pharmacist work that you're doing, because we incorporated it into our workflows, right? So some of the work is going to be absorbed. Can your retail pharmacy absorb it? Like, can they take the load off a little bit? So it takes a lot of collaboration for the hours and things like that. And the more kiosks you stand up, the more you have opportunity to centralize it, because that pharmacist doesn't have to sit there, and that's why retail pharmacies are expensive to run, because it's a physical pharmacy and you have to have a pharmacist sit there. Versus you have a centralized area, that'll definitely offset a lot of the costs. Yeah, so that we're still trying to managing the productivity of it month by month is tricky and things like that. But that's how we came out to the number, and that's kind of how we shot for broken even. Because from a pharmacy perspective, at least what I didn't want to happen was that we absorb it all, and they see that the numbers are positive, but they don't see my team sweating or the other team sweating. So and it's up to that leader how they want to approach it, if they want to absorb it or not absorb it. It was the first time. We just want to be as realistic as possible. We got line of sight, so I can guarantee you the way we're doing it today is not going to be the way we're doing it tomorrow.
Yeah, and that's the way it should be. It should be a kind of an evolving process. And it looks like, again, hopefully in the future, we'll be able to talk a little bit more about the next step of this. But what people need to what I capture from this study is that, again, putting these kiosks up or whatever device that you want to use, if you want to do it that way, putting a device up that allows a workflow that allows expanded coverage when it comes to discharging patients with medications. And everyone has a problem. This is a centralized theme in all EDs, no matter where you're at, because you can have pharmacists, but then you still probably don't have a 24-hour pharmacy within, hours of you. And this is going to become worse of a problem from my understanding, especially with nights and weekends, again, not being prioritized in the retail pharmacy world.
Hey, my family used it. We went through the ED, and they asked my spouse, like, hey, do you want to leave here with your prescriptions? And she was like, absolutely. It's kind of funny having it all come full circle. And I'm like, oh, this is great. We get to go home, and all the things. And I had some employees that rolled through it too. And it was great. The most refreshing thing I've heard was that, one of my leaders was a recipient as a patient, and now they want to put a kiosk on one of their inpatient units, which is like, because they kind of like, this is great. You're not going to have all the meds. If something could go wrong, it could go wrong. It's normal hospital stuff, whatever. But once it gets, it's pretty routine at this point, and looking to see how we continue to grow the process.
Or I think about it, it's like if I can reduce the number of, let's focus on the 72-hour revisits. If I can reduce those by any level percentage, my CMO, I know my ER director, my director of pharmacy here will be ecstatic. So I think just understanding what that looks like, and then we can tie dollars into that, FTEs into it. I think it's funny. My leadership always know if I'm coming to chat with them, at some point during that conversation, the FTEs can be mentioned.
So it's not just me. Sweet. I was gonna say something that was pretty funny, but yeah, it's a good process. And really excited for a new publication to come out that where we actually look at ED revisits in 72 hours and 30 days directly. And we also look at patient experience. So very positive stuff that we got from that. And now it was with our adjudication workflow. So that's why we came out with the part 1 and part 2. The reason for part 2 was just because of the impact of adjudication, which is very interesting learning, finding, but also, hey, like, let's settle it. Get a kiosk in the ED, reduce revisits, and let's see what the patients actually think about it, right? In this very competitive ED market where there's a offsite ED or HVED across everyone's street and things like that. So very positive stuff. So very excited to talk to you guys more about that next time, hopefully.
Yep, this was great, man. It's great. Happy we was able to kind of get back on. And I think just for the audience to kind of understand the significance of this moment, it's like, again, we started this podcast, 6, 7 years ago. Yeah, we built this, and then I remember mentioning a while back, like, hey, it'd be nice if we had a journal, it just throwing it out there when we was just young pups in the game. And then with the Society of Emergency Medicine Pharmacists popping up, and then with the Journal of Acute Care Pharmacotherapy popping up, it was a really, really, really cool thing to go from that aspect to me being kind of completely blinded out of the process and kind of understanding it. There was a guy named Oscar Santalo that submitted the paper, and it kind of going through independently and being able to work on getting the physical print, kind of seeing the first article in that. Again, the guy who I started this whole journey with, it was a really, really special moment. So I think that the audience need to kind of understand the significance of.
It saved me because people are hearing about the kiosks, and now I'm just like, no, read this paper. because I was kind of done with everyone was very interested, everyone was very excited about it, and the data collection, all the stuff to report out to, and now I'm just like, hey, just review this paper. Let me know if you have any questions. Check out this great journal that these guys actually came through on. No, very excited to get published through you guys. That's all very exciting from where we to where we are.
Yep, man. I think Zap will be pretty proud of us for where we came from. So shout out to all of our co-residents, all 35 of us. What was it that time?
Yeah, at the big house. So it was good. It was a good
Shout
time.
out to Advent. Even with Florida Hospital, the OGs of Florida Hospital Orlando, now Advent Orlando. So shout out everyone there. Shout out to my current spot. Just super excited where we are today. We got to hopefully be doing this again sometime soon.
All right, man. Well, thanks for having me on. I appreciate it. What was it? Yeah, keep farming hard, y'all.
It's been a while, but thank you guys. Thank you all for coming on, and we will check in with you guys later.
All right, later, guys.
Closes it. Ozzy scratches his head. Whatever she's looking for, it isn't in there.
Perfect.